So we're going to have a bit more of a talk about the concept of multisensory integration. So within osteopathic manual therapeutics, there has been research done speaking about multisensory integration and taking very, very small studies and experiments with osteopathic students in the UK, I believe. So there was a fourth-year student, a fifth-year student, and a practitioner who had been practicing for a certain number of years and had also taught students. Now, what they noted was that there were certain times when all groups used visual alone or visual information alone. There was times when they used haptic or palpatory information alone, and then there were also times when they, or the majority of the time rather, they used a combination of visual and haptics. Also audition or hearing would come into play if at such a point as a patient was responding to tenderness, they may make noise. So either the patient moves on the table and their body makes noise against the table, or they will make an audible noise. So these are all things that have been observed in very, very small experiments. Now, one of the things within it was actually somebody's PhD thesis that I was reading, what they spoke about was that with multisensory integration, one of the challenges is that when using palpation and vision, the structure that you're palpating is obscured from vision. Now, this is why multisensory integration comes into play, because I can join what I feel and what I see together. One of the things I want to talk about, just very briefly, this won't necessarily take a long time, is that I'm going to use my vision not absolutely to tell me what's happening under my hand per se. I may be using it to tell me if the motion that I'm creating is happening where I want it to happen. So if we do something such as, I'm just going to have you bend your knee. We have our patient bend the knee, and I go and I palpate through the trochanter as an option or as an example. Now, I cannot see the trochanter, but I can feel it, and I can see broadly what's going on. So if I'm moving the patient's hip, I know that that's hip motion. As I get over here to at a certain point, I'll start to notice the patient's pelvis rock. Now, you may not necessarily be able to see it, so I'll try to show you just with one hand. It may not work, but as I do that, eventually the patient's pelvis rocks. So I know at that point, just by looking at my hand and using my peripheral vision, that the thing that I'm palpating has come to the end of its useful motion in this position, and then auxiliary motion has happened somewhere else. Now, we can do this in a lot of other places. So let's just say I want to take the calf, generally speaking, across fiber direction. I want to bow the muscle in relation to the bones. I can drag the muscle across, right? So I'll try to make that a little bit more clear. So I have to stabilize because of the position that the leg's in. This is just a unique quirk of this. Now, if I'm not careful, you see the patient's knee move. Now I can look and I can see the patient's knee move. So now I know that one of the things that I'm trying to do is not occurring appropriately. The hip is moving too much. So I have to stabilize the shin, or the leg below the knee, the anatomical leg proper. I have to make sure that I can see where my hand is going, but in my peripheral vision I also need to make sure that we don't have the leg rocking around too much. So as far as the trouble with the structure being palpated, being out of vision, I may not necessarily be using my vision in that way. I can use watching my hand and the motion of my hand as something I can combine with my palpation, but I can also use my vision to make sure that I'm doing what I want to do, that I'm not accidentally or purposely creating auxiliary movement beyond what I want. Another thing to speak about is, as far as vision is concerned, there will be times when it's much more appropriate, as far as the comfort of the patient, to use your peripheral vision. So if you are sitting at the head of the table, looking straight down the midline of the patient, whether male, female, or other, it is much more appropriate to turn and use your peripheral. One of the reasons is because most people won't feel particularly comfortable when you're staring directly down their midline. Now, there's a lot of other situations such as this, and I believe that everybody is quite capable of figuring that out. So just as a general concept, sometimes you should look, it's quite acceptable to look directly at what you're working with, and other times it's much more appropriate to use your peripheral vision. So just, again, reiterating that with multisensory integration, or that concept, when utilizing it, there is a challenge that the structure being palpated is obscured from vision. However, that may not be the best way to use my vision. I can use my vision to look and see if my hand is traveling. I can also look and see if auxiliary structures are traveling. So we want to use that to the best of our capacity.